So thank you all for giving me this opportunity. My name is Emmanuel Mawuli Anane Whyte, a researcher and the Bardin Health Economist, and my co-author, Professor Edward Nketiah-Amponsah, who happens to be the head of the Economics Department at the University of Ghana. And our research is obesity and selected health outcomes in Sub-Saharan Africa, the role of regulatory institutions. I must say I dedicate this research to my wife and my two kids, Jaden and Damien. Now, this research is going to help us to see what obesity is in the first place and why it's a problem for the countries in Sub-Saharan Africa. The structure of the presentation will be in three parts. The first part will tackle the introduction, which will highlight the problem statement and also the literature review, also giving us the research objectives. Now, the second part of our presentation will be the methodology and also the data requirements for the research. And finally, we'll look at the discussion of the results and also policy implication. Now, when we say obesity, what is it? Okay, according to BRAE 2000, it defined obesity as an event or an occurrence when there is a mismatch between the energy, okay, that is consumed in food and the energy expended. So there is always a difference in energy, and this is retained in fat cells which grow and or multiply. In terms of measurement, the World Health Organization says that if an individual has a body mass index, that is BMI, of about 30 kilograms per square meter, then and above, that individual will be described as obese. But why is obesity a problem? CARDS 2000 helps us see that obesity is linked to a high probability of diabetes and some cardiovascular diseases like heart disease. Years ago, infectious diseases such as hepatitis and measles have been key contributors to the disease burden in Sub-Saharan Africa. Sadly to say, countries in the region, like other developing countries, are undergoing a change in disease burden. Now, what is this change? Non-communicable diseases are becoming more prevalent as compared to communicable diseases. Gutta et al. 2019. Now, one of the reasons that has been given for the increase in obesity rates in the Sub-Saharan African region is the increase in consumption of SSBs, we call the sugar-sweetened beverages. Why? Because SSBs has been associated with weight gain due to their high energy levels and low nutritional content, among other things, by CARDS 2000. So why is this research needed to our problem statement? Obesity rates in Sub-Saharan Africa are predicted to rise, resulting in higher healthcare costs. Already, the African region is battling with increasing healthcare costs. With obesity rates rising, this is going to be problematic. And because of the increased use of SSBs, it's going to lead to prevalence of diabetes and also some more cardiovascular diseases, as predicted by the World Health Organization in 2017. Diabetes is also on the rise in Sub-Saharan Africa. Although advancement in age is still a threat for type 2 diabetes, it is anticipated that there will be a trend towards earlier onset. In 2013, for example, the reported diabetes cases in Africa were among those below the age of 60, with peak onsets occurring between the ages of 40 and 59 years. However, in 2021, the World Health Organization recorded that diabetes is now among young adolescents aged 18 years in Sub-Saharan Africa. So this is a problem, and if we do not tackle it, then we are going to be in a serious trouble. In terms of literature review, there are some studies that have also examined the effect of obesity on some health outcomes. For example, Ajiman et al. 2016 examined the prevalence of overweight and obesity in Sub-Saharan Africa, as well as their factors and links to cardiovascular diseases and diabetes. And more interestingly, they realized that being obese is linked to an individual being diagnosed with diabetes and other cardiovascular diseases. Odain, Levy, and Elahi also investigated how sugar-sweetened beverages intake in children is likely to also aid in they being diagnosed with type 2 diabetes. In Tanzania, Nketiah et al. 2009 reports that a 1% rise in body mass index was linked to a 10% increase in the risk of an individual being diagnosed with hypertension. In a related study in Nigeria, Opechi et al. 2013 says that if an individual's BMI is 25 and
হ্যাঁ,
above, then
মামাকে
that
আমি মেসেজ
person
পাঠাইছি একটু
is
থাকতে বললাম
likely
তো।
to
আর হচ্ছে যে
have
আমি ডিসকানেক্ট হয়ে
diagnosed with
গেছি। এখন তো আমি
hypertension, and that
হ্যাঁ, হ্যাঁ, আচ্ছা।
increases by 12% and not 10% in Tanzania, as stated earlier. Also, there was a Swedish obesity study by Bray in 2004, which also indicates that hypertension was prevalent in 44 to 51% of patients that were also taken through the study. And interesting to note, they opined that controlling for obesity would remove 48% of hypertension in whites and 28% of hypertension in blacks. Hypertension also is linked to increased prevalence of stroke. So if this obesity problem is not solved, then we are looking at more cardiovascular diseases. Now, despite the fact that there has been some studies on obesity and its effect on health, none of these studies have examined how government policies via its regulatory institutions could help reduce obesity rates in Sub-Saharan Africa using the generalized method of movement methodology, making this research novel. Now, what are our research objectives? Three of them. One, we want to examine the effect of obesity on three health outcomes, i.e., diabetes prevalence, mortality due to cardiovascular diseases, and life expectancy. Second, we examine the effects that regulatory institutions have on these three health outcomes. And finally, we want to examine how regulatory institutions moderating obesity, what is the effect it has on these three health outcomes. To our methodology, this research was based on the Grossman's 1972 demand for health model, which was later simplified by and extended by Wagstaff in 1986. And that is the theory underpinning our study. So using the health production concept, for example, we assume that people manufacture health by utilizing various socioeconomic and non-socioeconomic variables. So to our first equation, health is a function of socioeconomic and non-socioeconomic variables. Therefore, to our second equation, health can be said to be a function of these socioeconomic and non-socioeconomic variables, including education, the person's income, occupation, the person's diet, recreation, or even the person's ability to engage in physical exercise. Looking at the research objective that we have, we want to find out if regulatory institutions can moderate obesity to have any positive effect on health outcomes. So our equation 3, health outcomes, HO, is therefore given as a function of OB, which is obesity, law representing the regulatory institutions, and Z are control variables. To the dynamic form of our model is expressed in equation 4, where we are looking at HOIT, that is health outcomes in their current figures, as against HOIT minus 1, that is the first lag of the health outcomes. We are looking at its effects, looking at obesity, law. Now we look at the moderating effect of regulatory institutions that have on obesity and what would be the effect on health outcomes. Now these other variables are control variables like undernourishment, unemployment, urban population, GDP per capita, and immunization. These have effect on our health outcomes like life expectancy and prevalence of diabetes. So we need to control for these effects. That is why it is in our equation. Now, what is the data that we use for the research? This data was sourced from the World Bank's governance indicators and the rule of law component, okay, while the rest of the data, both dependent and control variables, was sourced from the World Bank development indicators, And we're looking at 26 SSA countries, and the period was from 2005 to 2019. So that is a panel data for us. Now, what will be the estimation technique to help us so that we can make meaning out of this research? Looking at the panel data, there is a presence of potential endogeneity in our model. So once we use OLS to estimate, our results will be inconsistent and biased. Research has shown that there are other alternative estimation strategies to use when we have a model like that, like the instrumental variables or the two-stage least squares. But the problem is that these two rely on external instruments. And sometimes these external instruments should be able to be correlated with the endogenous variable, at the same time uncorrelated to the stochastic error term. Finding these external instruments becomes problematic. Therefore, the panel data model works best if we use the generalized method of moments, the GMM estimation technique, because it can handle the dynamic panel bias problem caused by endogeneity. So that is what we use in our regression analysis. What are the results once we did that? Interestingly, look at it. Obesity, or a percentage increase in obesity, leads to a 0.55 reduction in life expectancy, and that is statistically significant. A percentage increase in obesity rates in Sub-Saharan Africa also leads to a 0.03 percentage increase in diabetes prevalence. And finally, on our last health outcome, a percentage increase in obesity rates also leads to a 0.77 percentage increase in death due to cardiovascular diseases. And this is not different from our a priori knowledge that once obesity increases, it reduces life expectancy. It also increases diabetes prevalence and also increases death due to cardiovascular diseases. Now, the purpose of our research is, can regulatory institutions help? So let's find out the outcome of that. The mediating role or moderating role of regulatory institutions through obesity. What is the effect on our three health outcomes? Now, if you look at OB interacting law, let's find out the results. We realize that if regulatory institutions moderate obesity, there are positive effects on health. Okay, thank you. Once regulatory institutions moderate obesity, it increases life expectancy by 0.09 percentage points, reduces diabetes by 0.007, and also reduces death due to cardiovascular diseases by 0.13 percentage points. What is our conclusion then? Obesity prevalence must be reduced in order to have improved health outcomes, according to the literature. Now, this alarming situation prompted us to do this research into how quality regulatory institutions can help the region achieve better health outcomes through reduction in obesity prevalence. And that is exactly what happened in our research outcomes. As a result, many governments across the globe, particularly those in Sub-Saharan Africa, must commit major amounts of their revenues to strengthen their regulatory institutions to aid reduce obesity prevalence in the region. To our limitations and future research, we do not recommend generalizing the findings due to the small number of SSA countries that we have considered. We also, for future research, recommend that childhood obesity is on the rise. Hence, future researchers can also focus on the effects of childhood obesity and also its health consequences for the region. Thank you.